I would challenge, if you don't mind, I don't believe they were materially different. There was a couple of words about population health missed and something. That was entirely a transcription error from the original terms of reference to the final document. The terms of reference never changed. We never changed in our endeavours when we were out there. We always intended to look at population health issues and patient safety issues. I do apologise that caused confusion.
Well, I thank you for the apology. I think it does. It's created a lot of mistrust in a situation where there's already mistrust, and I think that even the fact that the words were like system learning, that's a pretty big piece of information whenever it comes to a review of what's happening in a situation like this, and for it to be removed in the final version kind of give the suggestion that there were no system learnings, or that wasn't a focus, and the patient population outcomes. Obviously, if you're talking about moving emergency surgery, there could be nothing greater to the patient or the personal outcomes than that. So, but anyway, maybe just...
May I just quickly say, though, whilst I do accept entirely the point you're making, it caused confusion, I do apologise for that. But actually the outcome of this has actually been system learning.
Yes.
I mean, I know you may well have looked at the Department of Health's response, and I really do want to emphasise that the learning out of the Western and Southwest Acute has led the department to determine that all service change in future, temporary or permanent, will be subject to independent evaluation at 6 months, and will have already led up to it a clinical audit programme. This is really, really important, because we know as a community we are facing into service transformation. Hospitals are going to be different. Yeah. This is now a commitment, learning from SWA, that in future this will be the norm. So there couldn't be anything further. I mean, this is the most obvious example of the system learning, despite the terms of reference causing that confusion.
And just additionally, the systems learning depends on connected data and information, so that we can really develop that into evidence, and I think Encompass will help with that. But there's other parts of the health and social care system where we need to be also accessing data. So, for example, NIAS needs to talk to the trusts, etc., in terms of real data, and so there's, I think, still a lot to do in terms of that digital transformation.
There were 80 patients that were part of your patient experience piece that you did. That is that a good number of people, or is that a regular number of people, or is that a low number of people in terms of these types of...
I would say this review is not typical, but in terms of engaging with a number of people, that would be exceptional. That would be a high number of people that, and you will have noticed too, a significant number of frontline staff we engaged with. But, and I'm not saying that we've received everybody's views and so on, but that would be quite a significant number of people, yes.
If there was an exceptional number of people, in your own words,
yes,
and you made 10 recommendations, why are none of them relating to Section 7, 8 and 9, which is to do with patients, families, staff and stakeholders? If they all engaged in the process and told you their views, but whenever it came to your outcomes, you haven't provided any outcomes that addresses their issues, and it was an exceptional number of people that were engaged in that process, they might feel a little bit left out as a result of that.
I hope not, because I actually wrote a paragraph leading into that section to say that they underpin all of the recommendations. We don't attribute recommendations to the public. The public are not accountable for making the recommendations. We listened to their experience, and it has led to all of the recommendations. I actually wrote a little paragraph leading into that section, or at the end of it, to say, you will note that none of the recommendations are directly related to patient experience, because they're not accountable for it, and they shouldn't be, that's a direct consequence from somebody telling us something. We triangulate, or whatever word you want to use, information we receive from patients and their families, with clinical information from frontline staff, and the recommendations are ours. We're accountable, we're responsible, and the public and patients have informed that.
Not so sure people engage in a process to be triangulated, but I think they want to be able to see their recommendations in the report, but there was some of it there. My final question is, if people, as a result of this process, are having to move from the SWA up to Altnagelvin, that's a considerable distance. It's going to be a considerable impact on those individuals that have to be moved at some of the most difficult times in their lives. I would have thought that it's a small point, but that there might be some impact on the medication that they have to take, or the medication that is administered to them, or the handling of their medication. Would that have been something that was
mentioned to us.
Mentioned or
Yes.
discussed?
Oh yes, many patients mentioned medication to us. But the important thing about, well, I'm reflecting from the review, the important thing about patient experience is what we wanted to hear from patients and reflected on and their families was how they were treated, how they felt, what they observed, all of that. Though we identified in the report things that lots of people told us, particularly the second wait in ED, people found really distressing and all of that. The journey they found distressing. Medication management, prescribing and administration of medication is unique to each individual. I can understand sometimes patients may have their concerns about it, but it is a part of clinical practice. It's not a patient experience issue, it's a clinical practice issue. And we would expect that to be examined thoroughly in the clinical audit programme, because the management of medication, clinical decisions, the journey from Enniskillen to Londonderry, all of those things may have an impact on the clinical outcome for a patient. But I know we will understand that medication prescribed to someone will take account of their condition, their comorbidities, their age, a whole range of issues. That is not an experience issue, it's a clinical practice issue, and we would expect that covered in the clinical audit.
The report doesn't mention medication anywhere?
No, it doesn't mention it in the patient aspect, because well, it was not these are personal issues to patients about their medication. We've mentioned throughout the report about the need for clinical audit. And clinical audit would also cover medical decision making. It would cover medication management. I'm sorry that the report doesn't mention every aspect of clinical audit, but I would expect medication to be a key part of it. I'm sure as a medic, Stuart, you would expect the same.
And I think the management of medication is that there's adequate transfer of information from SWA to ambulance to admission into Altnagelvin, and that should be a routine area of audit undertaken within the trusts.
I'll leave it at that. I just worry when we say should be. You've completed a report. The idea of a report